So guys, last week I took you all with me on night shift in the ICU when I picked up a shift to help out due to short staffing. Now, I'm going to share the story with you guys because it has been weighing heavily on me, and I just need to get it out there, so bear with me. It's not going to be long. I arrived at work, and upon arriving, I was told that I would have an orientee with me. And I was like, an orientee, like y'all know I'm PRN and I don't even really work night shift. But, you know, I'm always up to precept. I love teaching. As you guys know, I have a master's in nursing education. So I was like, cool, who is it? So it's this very nice young lady. I introduced myself to her and I asked her, you know, how long have you been on orientation? And are you a new nurse? So she had been on orientation for about 4 weeks. And she is not a new nurse. She is a new to specialty nurse, meaning that this is her first ICU experience. So I'm like, okay, cool. You have basic nursing skills, assessment skills. You know the computer system because the hospital in which she worked previously shared the same system as the current hospital, the current ICU that we were in. So I'm like, okay, good. So you're good with documentation. You're good with basic nursing care. I am going to be here just as a resource, your tech, and just overall help if you need it. If you need anything from me, you have to let me know. You have to call me. You know, every once in a while, I'm going to check in with you. Every once in a while, I'm going to take a look at your documentation to see exactly where you are. But I'm not going to micromanage you. I am not a micromanager. I do not like being micromanaged. So we set up the expectations for the shift. I told her what I would be looking for. And she was like, yeah, I'm good. We were assigned 2 rooms. One of the rooms was an empty. And the other room had a patient who had to have been the sickest patient in that back hallway. And this patient had just came from the OR, received multiple blood products, was on massive transfusion protocol. So he was due to have more blood products, and we just had a lot of work to do on him. He was on a lot of drips, sedation, just a very sick man. So I said to her, okay, you're comfortable with these drips, whatever the case is, let's go. Patient was also COVID positive, by the way, so just to add another layer on top of it. We go into the room and she starts doing her thing. Like I'm talking about listening to lungs, making sure suction was set up, pulling the gown back, taking a look at the incision, looking at his urinary catheter. She took a temperature and she was like, I'm just going to start doing my assessment in here. So I was like, okay, you seem to have control of what's going on. Then we realized that the patient needed more blood products. She went ahead, she ordered it, so on and so forth. So she is doing her thing with no problems at all. I actually like the way that she was working. So I'm like, this girl, you know, it's going to be a good night because y'all know me. I don't work night shift. So I'm like, I'm glad I'm with her. Anyway, I leave her in the room. I go out. I get the blood products when they come. I hand them to her. She would call me on the Vocera device if ever she needed anything. Like just really keeping up with her work. At some point, the girl who's her original preceptor comes over to me and asks me, how is she doing? And I was like, she is doing great. She was like, well, for me, it seems like she's slow to catch on. She's not really taking initiative. Like, I don't know if she's just not interested. So I'm like, well, that's not my experience with her. She's doing amazing. I'm out here and she's in the room taking care of the patient. Her documentation looks fine. Like, no issues at all, right? So then another nurse comes to me and says, Kendra, this is the most we've seen. Let's call that nurse Mary. This is the most we've seen Mary do her entire time on orientation. Because every other time, and when she's with her other preceptor, she's kind of just following and observing. With you, she's actually in the room working, taking care of the patient. So I'm like, yeah, she's been on orientation for 4 weeks. I established trust with her. And she's been calling me when she needs me. She hasn't done anything for me to have any kind of concern. And they were like, well, that's good that she's getting to work like that. So after hearing that, and after speaking with her preceptor, or her preceptor inquiring about her progress, when we had a one-on-one moment, I asked her, I said, what's been going on your orientation? Because, you know, your preceptor is saying that you're not really catching on, you're not really keeping up, and she doesn't know whether or not you're going to make it in this kind of environment. And the reason why I brought it to her attention is because I'm not doing that back and forth BS. he say, she say. If your preceptor comes to me and says something about you, it is my responsibility to let you know what's going on. So I asked her, I'm like, has your preceptor had any of these conversations with you? She was like, no. I said, okay. She said, the problem is she won't let me do anything. If I go into the patient's room, she's telling me I can't go into the patient's room without her. If I try to make a change on the drips, she's like, oh no, I need to let her know first. Basically, she's been micromanaging me. Not only has she been micromanaging me, she does not speak to me other than anything to do with the patient or patient care, or if I ask her a question. Most of the night, she is with her group of friends and they're laughing, having a good time. If I go to her and ask her a question, it's as if I'm bothering her. And she's like, I've just been sitting around just waiting for her to come back from her little gatherings with her friends in order for her to go into the room. Then I'll follow her and see what's going on, right? So I said, well, that's not the way it's supposed to be. You're supposed to be taking care of the patients independently with minimal cues and minimal guidance. So, you know, whatever. Keep doing your thing. Not too long after, we get an admission from the ER, and it's a trauma admission. This patient comes up, gunshot wound, super sick, needed to go back to the OR, blah, blah, blah. All of this is going on. So now we have two very sick patients. And guess what? She adapted very well. With the second patient, she was like, okay, I'm going to finish off everything with the first patient, and then when this other one comes back from the OR, then I'll start doing this. Like, she had a plan, and she was able to verbalize her plan to me. So I'm like, yo, this girl is doing her thing. During the night, I said to myself, at some point during the night, I said, let me go have a conversation with her preceptor. So I went to her preceptor and I said, you know, you came to me earlier and you inquired about her, and all of the concerns that you're having, I'm not seeing that. So I said, let me ask you a question. And this is not to be disrespectful in any way. How long have you been a nurse? She replies, it's going to be 2 years. So I said, okay, you're a novice. According to Patricia Bennett's theory, Benner theory, you're a novice nurse. 0 to 2 years, you're a novice. Meaning that you're just starting out in the career. You use a lot of the textbook to guide your practice. You're not able to bend and flex the way an experienced nurse like myself would. I've been a nurse for 12 years. Not only have I been a registered nurse for 12 years, I've also worked as a nursing assistant for 4 years while I was in nursing school. So that experience counts for something. Like, I'm very in tune with patients. I said to her, because you are a novice nurse and you've been given the task of precepting, you're not ready to precept because you're still a novice. So you and a new grad, you guys aren't that far off from each other. It's really a case of the blind leading the blind. I said, let me explain something to you. This new nurse, Nurse Mary, new to the hospital, new to the ICU, is not a new nurse. She comes in with nursing experience, meaning that she already has a routine down packed for herself. Your job as the preceptor is not to change her routine, but in fact, guide her on how her routine can be adapted into the ICU, share tips and tricks, and share rationales as to why it's best to do this first. Your job as a preceptor is not to change how she nurses. Every single nurse have their routine. For example, you might have a nurse come in who will say, I want to look my patients up, go into the room, do assessment, come back out, read some more on the patient, look at orders, and then give meds. You have some nurses come in and say, all I'm checking is the orders. I'm going to pull my meds, reposition my patient, do this, whatever it needs to be done in the room, and then I'll come out and I'll chart my assessment. Is any of the approaches wrong? No. As long as the patient is safe and having positive outcomes and we're meeting the plan of care, there is 15,000 ways a nurse can choose to nurse so long as she's safe. And this is what I was explaining to the preceptor. I then go on to say to her, you also have to understand, and this is the key part here, you also have to understand nurses that are new to the ICU, especially Black nurses, tend to be very careful and tread lightly because historically ICUs have always been predominantly white. It was very rare to find Black nurses in the ICU setting. I said, so when black nurses come into the ICU, and I told her, I said, this is no fault of your own. This is me just sharing something with you so you can be more aware, more self-aware as to why maybe you think she's acting a certain way. I said, when we come into the ICU settings, we already come in being pre-warned that this is an environment where we might be targeted and where we might be ousted. We are taught, even like in nursing school, that the ICU is typically not a place that welcomes black nurses. And I made sure and I emphasized to this preceptor, like, I'm not blaming you for that. And I hate that this is the way things are, but I have to make you aware that when you're saying she's not showing interest or you have to ask her questions, she's not asking you questions or whatever the case is. I said, you have to kind of take into account maybe what's going on in her mind, or you have to become more self-aware and say, am I doing something wrong? You should not immediately jump to the conclusion that she doesn't know basic nursing care, she doesn't know this, she doesn't know that. I also said to her, as a new grad or as a new nurse or as a novice nurse, you're also going to micromanage because you don't know how to let go. I said, with me as an experienced nurse, I establish trust. Trust is the first thing I establish with any student or with any new nurse that I'm training. Like, hey, don't do anything you're not comfortable doing. If you don't know something, come and ask me. There is no barrier asking me. You're not going to be ostracized. I'm not going to be like, oh, you didn't know, because it is my job to educate you and teach you and get you up to speed to where you need to be. So I also explained to the preceptor, if the person you're orienting is afraid of you, based on how you've been acting, you and your friends, you and your little mean girls crew, you've created a barrier to where she doesn't even feel comfortable coming to you. So she's not having a good experience with you. Anyway, the night continued on. The young lady did excellent, superb. I decided to go to the manager in the morning and have a conversation with him just to let him know, just in case you've been hearing anything negative about this nurse, please throw it out the window, because she was with me last night and she did fabulous. And I have a pretty good rapport with people in management. They know that I've been in this institution for a long time. They also know I have clinically instructed in the past. I have a degree in education. I've oriented countless amounts of students, new nurses at different institutions in the past as well. So they know when I give feedback, my feedback is legitimate. Like, I'm not sugarcoating or BSing. So I told them, I'm like, I think what's happening is you probably don't have enough experienced nurses on the floor to precept, but you need to give her another preceptor who has more years of experience, who is not a novice nurse themselves. A nurse of 0 to 2 years really should not be precepting a new nurse. I mean, what can you tell them? You don't know anything. And I'm not saying that to be insulting, but you really, truly do not understand. Nursing has nothing to do with the amount of degrees you have in your education. Nursing is really based on experience. I mean, back in the days, nurses came out of school with a diploma degree. Like, they didn't have to have college credits and go to college to get a nursing degree. They learned hands-on in the hospital. They lived on campus and they worked in the hospital as they learned. So just because you went to a top-notch university and might have graduated with a 4.0 degree does not make you a good nurse. It doesn't. All right. So when we were done, the shift was over, I made sure I gave her my phone number and I said, hey, if you have any questions, any concerns, you can call me. I also gave her some suggestions and some tips. And I also told her, like, listen, in this kind of setting, you have to advocate for yourself. I'm like, being timid and being modest and not wanting to ruffle feathers in this kind of setting does not work, okay? So I said, call me if you need anything. She told me she would, and she was scheduled to work again later on that week. Apparently, when I followed up with her, she came back to work, and the preceptor had not changed much. Preceptor was still using the same kind of approach. And also another thing that the preceptor was doing, I heard, was going around and speaking negatively of the orientee, saying that she doesn't know this, she doesn't know that. And I'm just like, what kind of toxic environment is this? Like, I was really surprised that this was even happening in this ICU that I work in, because I Have never heard. I'm typically day shift and we don't have that kind of drama. Or if we do, I don't know about it because I don't tolerate that kind of behavior. So basically, things did not get better between her and her preceptor. Even though I had asked for her to be switched to someone else, that didn't happen. And she also did not advocate for herself to get switched to another preceptor. Once again, not wanting to ruffle feathers. A couple days later, I saw the educator, the woman who's in charge of like the residency program and precepting and all that stuff. And I went to her and I said, hey, I worked with such and such the other night. She is excellent. And she was like, I'm really happy to hear that because the feedback I've been getting on her has been very poor. I said, the feedback you've been getting on her is very false. I said, it's a false narrative. It is not true what they're telling you. And you need to give her another preceptor. That never happened. So the other day, I text that orientee just to check up on her and see how things were going. And she said to me, I asked her, I said, when are you scheduled to work? And she was like, I'm supposed to work Friday and Saturday, but I'm not coming back. I was like, what do you mean you're not coming back? She was like, I can't handle it. The passive aggressiveness has increased. She was like, and I'm afraid that they're going to report me. They nitpick at every single thing, and I just don't want to be fired. So she was like, I'm just not going to come back. During that phone conversation, I pleaded with her. I said, girl, do not leave this ICU. I'm like, you wanted to come to the ICU. You're here. I gave you a very good evaluation. Like, I see something in you. I know that you can handle this ICU. Come back. Do not let anybody drive you out of your experience, drive you from your job. And I spoke to her for a few minutes, and towards the end, I thought I had gotten through, and she was like, okay. But I guess she was just appeasing me because I was at work 2 days ago, and she was supposed to come in on night shift, and I went to go look for her, and she didn't come. She didn't call. She didn't show up. So I've been pretty upset about that because I feel like there are a lot of good nurses, new nurses who are willing to learn and willing to be trained that end up exiting the organization because of the violence. And yes, I refer to it as violence. Nurse bullying is definitely violence that they experience in the workplace. When you have a clique of girls who are friends and all they do is nitpick and talk about and decide who they're going to help and who they're not going to help and criticize in a negative way new nurses, that's not an environment that's supportive of learning. As a matter of fact, that kind of environment is very toxic, and I think it contributes to poor patient outcomes. I do work tomorrow. I'm going to follow up with the educator and the manager to see if they reached out to her. Maybe she can give like an exit interview. Maybe she can really tell her story, because I felt like the only time anybody heard her story was when I advocated for her. And the reason why I feel really bummed out about it is because she did well with me. And we had the 2 sickest patients in the back, and she did well. Of course, she needed a little bit of guidance, but she would have eventually gotten to be up here. Like, she was just right here. And I think with the right preceptor, she would have been right here. And sorry, I don't know what happened with that last clip. The camera just kind of shut down. But anyway, I'm going to follow up when I go to work tomorrow, Monday morning, to see maybe if they can reach out to her and possibly salvage the relationship, being that this girl actually left because of the passive aggressiveness and the lateral violence and the bullying, the nurse bullying that she had experienced at the hands of a very novice preceptor. That's what's blowing my mind. The one thing I tell a lot of my nursing students who are graduating, or even new nurses new to specialty, is keep record of everything that happens. Keep a journal, so that way, if in fact you do advocate for yourself, you can pull out your notes and have examples to say, on this day, you know, I was with such and such preceptor. We took care of these 2 patients in these 2 rooms. This is what happened. I went to ask her a question. She dismissed me. Like, you all need to keep record, because you have to fight back against this system, especially if, and I hate to go here, especially if you're a Black nurse that's in ICU. It is going to be a challenging experience because historically, we were not let into ICUs. Shit, historically, we were not even allowed to be nurses. So there's challenges that we still face because it's been a system in place. And that is the reason why, too, I shared my story on the ICU gatekeeping. Like, I have a 3-part series on ICU gatekeeping, telling you my experience of what I had to go through to eventually become an ICU nurse. And I think my theory, part of the reason why there's such gatekeeping in the ICU, is because in order to become a CRNA, a certified registered nurse anesthetist, which is the highest paid advanced practice nurse, you must have ICU experience. You must have at least 1 to 2 years of ICU experience. In order to go to CRNA school, you have to have really good recommendations from your manager. You have to have like experience taking care of a certain kind of patient. And that can only be found, you can only get that experience from being in the ICU. So there's a level of gatekeeping that I think happens to prevent some nurses from entering that high level, that high tax bracket, when your salary is literally can be over $300,000 a year. But I'm pretty bummed out, and I just wanted to come on here and share that with you all. I'll see you guys in another video. Have a good night.